this is Wilkins, Chapter 21, Dental Calculus. The dental calculus is a mineralized dental plaque that's filled with crystals of various calcium phosphate mineral salts between previously living microorganisms. And calculus is always covered with a thin layer of non-mineralized dental biofilm. So you can never just have calculus alone. There's always biofilm over the dental calculus, and it contains viable active bacteria. The hard, tenacious mass forms on the clinical crowns of natural teeth, as well as dental implants, dentures, and other dental prosthesis. So be familiar with the terms and keywords associated with calculus on box 21-1 of the text. So a major objective in non-surgical periodontal therapy is to prepare the teeth through definitive biofilm and calculus removal to have a biologically acceptable, smooth surface to facilitate healing and prevent recurrence of periodontal inflammatory diseases. It's really impossible to remove all the calculus. We like to say that all the calculus has been removed, but statistically, the evidence is not there that it is really ever done. But we want a biologically acceptable, smooth surface. Comprehensive understanding of the characteristics, the origin, development, and methods of prevention of calculus is really important to patient examination, assessment, as well as treatment and instruction. For successful treatment and prevention, the patient needs to know the interrelationship between biofilm, calculus, and oral health, the need for complete removal of calculus, the best that we can do, and the reasons for the meticulous manner in which the scaling procedures need to be carried out, because they are going to get frustrated at times that it takes so long, especially when you're in school. But this picture shows you supragingival calculus on the cervical third of the mandibular anterior that extends slightly subgingival. Now that's A. B shows you supragingival calculus over the crown, the exposed root surface, and the margin of the gingiva. And then the C shows you subgingival calculus along the root to the bottom of the periodontal pocket, and then D is the periodontal pocket. So you're seeing A and B and D in the first picture, A, B, C, and D in the second picture, because there is a periodontal pocket. The dental calculus is classified by its location on a tooth surface as related to the adjacent free margin. That is it supragingival or subgingival? So a comparison of the supra and subgingival calculus is on table 21-1. But for supragingival calculus, it's going to be location as well as distribution, same way with sub. So the location of supragingival is on the clinical crowns coronal to the margin of the gingiva, on implants, complete as well as partial dentures. The distribution for the most frequent sites are on the lingual surfaces of the mandibular anterior teeth and the facial surfaces of the maxillary first and second molars. Those are opposite the openings of the ducts for the submandibular as well as the parotid salivary glands, the Stenton's and Wharton's ducts. Figure 21-2 shows heavy supragingival calculus forming a continuous bridge across several teeth. And on the crowns of teeth that are out of occlusion, that are non-functioning teeth, or teeth that have been neglected during daily biofilm removal, the toothbrushing and flossing and other things, it can accumulate. As well as on surfaces of dentures, dental prostheses, as well as tongue piercings, the barbells with the tongue piercing. I don't know if you've ever encountered somebody who has actual calculus deposit on those. It's quite appetizing. Now for subgingival calculus, the location is on the clinical crown apical to the margin of the gingiva and extending nearly to the clinical attachment on the root surface. It can also be on dental implants. For the distribution of subgingival calculus, it may be generalized or localized on a single teeth or on a group of teeth. The heaviest deposits are related to the areas most difficult for the patient to access during personal oral biofilm removal procedures. And figure 21.3 illustrates subgingival calculus on an extracted molar and premolar. The calculus typically will form at the CEJ as recession and pocket formation continue. And the color of subgingival calculus comes from exposure to the products of blood and blood breakdown products. So when calculus first forms, it's generally a creamy white, and as hemoglobin is leached into the calculus from bleeding, so to speak, even though the patient's not aware that they're bleeding, but from the lining of the tissue of the pocket wall, that hemoglobin will be absorbed into the calculus, and it will become dark, almost black-like. It looks like small pieces will look like pepper, large pieces look like gravel coming out. For the composition, you've got your inorganic and organic composition. Calculus is made up of both. The percentage vary depending on the age and hardness of the deposit, as well as the location where the sample is going to be taken from. Mature calculus usually contains inorganic components between 70 to 90% inorganic, and the rest is organic components as well as water. The chemical component of supra and subgingival calculus is really similar, but think about that inorganic. 90% inorganic, that's pretty hard stuff. What is the inorganic component of bone and enamel? Do you remember that? I mean, so this is very hard, tenacious calculus, the old stuff. The inorganic content, the major inorganic components are calcium, phosphorus, carbonate, sodium, magnesium, as well as potassium. Then there are trace elements of chlorine, zinc, strontium, bromine, copper, manganese, tungsten, gold, aluminum, silicon, iron, as well as chlorine. Now there is fluoride in calculus, and the concentration of fluoride in calculus varies depending on the fluoride intake of the patient. But teeth receive fluoride from fluoridated drinking water, topical applications, through toothpaste, or any form that's received by contact with an external source of fluoride as well as calculus. At least 2/3 of the inorganic content in calculus is crystalline, principally apatite. Predominating is hydroxyapatite, which is the same crystal present in enamel, dentin, cementum, as well as bone. So calculus also contains various amounts of brushite, widowite, and octocalcium phosphate. And I'm slaughtering these words, I apologize. Dental enamel is the most highly mineralized tissue in the body, and that contains 95 to 97 inorganic salts. Dentin is 65, and cementum in bone is 45 to 70. So if calculus is 90% inorganic, it's almost as hard as the enamel. Mature calculus has approximately 70 to 80% inorganic content. A comparison of the calculus with the tooth parts provides insight to the effects of instrumentation, the difficulty in really distinguishing calculus from cementum or dentin when you're scaling subgingivally, and the modes of attachment of calculus to the tooth surface. For the organic proportion of calculus consists of various types of microorganisms, desquamated epithelial cells, leukocytes, and mucin from saliva. Substances identified in the organic matrix include lipids like fatty acids and phospholipids, as well as proteins. Calculus results from the deposition of minerals into the biofilm organic matrix. Calculus formation occurs in three basic steps. You've got your pellicle formation, your biofilm formation, and then the mineralization. And mineralization of supragingival and subgingival calculus is essentially the same, but the source of the elements for mineralization is not the same. So for pellicle formation, the pellicle or cuticle is composed of mucoproteins from the saliva and is an acellular material. And the pellicle begins to form, as you know, within minutes after all the deposits and the pellicle's been removed. Then, for biofilm maturation, microorganisms settle into the pellicle layer, colonies are formed, and in early calculus, the colonies consist primarily of cockeyed and rod-shaped organisms. And by the fifth day, the biofilm is mostly made up of an filamentous organism. But the colonies grow together to form a cohesive biofilm layer. And then you've got the maturation, which is your mineralization. And there's early calculus formation. And mineralization centers, they're undisturbed within 24 to 72 hours. More and more mineralization centers develop close to the underlying tooth surface. Eventually, the centers grow large enough to touch and unite. Mineralization first occurs within the intermicrobial matrix, and the filamentous microorganisms provide the matrix for the deposition of the minerals. So as the deposit ages, mineralization within the bodies of the bacteria occur. Then you've got a calculus, like substance that was put into for animal studies, for germ-free animal studies. A calculus-like deposit was observed on the teeth in a germ-free animal that had no biofilm. And that may indicate that other organic substances like the pellicle may mineralize. But the pellicle is between the dental biofilm and the tooth surface. And since the attachment of calculus is very strong, it's expected that the pellicle must also mineralize to create such a firm bond. For supragingival calculus, the source of minerals or the elements for supragingival calculus is the saliva. The gingival sulcus, the gingival sulcular fluid is for subgingival calculus, and the inflammatory exudates supply minerals for the subgingival deposits. And because the amount of sulcular fluid and exudates increases with inflammation, more minerals are available for mineralization of subgingival biofilm. The mineralization consists of crystal formation, mainly hydroxyapatite, octocalcium phosphate, whitlockite, and brushite, each with a characteristic developmental pattern. The crystals form in the intercellular matrix and on the surface of bacteria and finally within the bacteria. The mineralization process is considered the same for both super and subgingival calculus. Now, calculus formation is affected by factors such as salivary flow, salivary supersaturation with calcium phosphate salts, and inhibitors and promoters of calculus formation. Calculus inhibitors include pyrophosphate and zinc salt. Some people have natural pyrophosphate in their saliva. They don't produce calculus. Now, pyrophosphate is one of those ingredients also in the tartar control formula toothpaste that's added, as well as zinc salt. Calculus promoters include urea and silicon. Rice-based diets can have a higher silicon content and contribute to greater calculus formation. The difference between supra and subgingival calculus crystals is the calcium to phosphate ratio is lower in supragingival calculus. Heavy calculus formers have a higher salivary level of calcium and phosphate than do light calculus formers. So what is the structure of calculus? For calculus forms in layers that are more or less parallel with the tooth surface, and the layers are separated by lines that appear to be pellicle that was deposited over the previously formed calculus. And as mineralization progresses, the pellicle then becomes more embedded. And the lines between the layers of calculus can be called incremental lines. And they form around a tube in supragingival calculus, but they form irregularly from the crown to the apex of the root in subgingival calculus. And the lines are evidence that calculus grows or increases by the apposition of new layers. The surface of calculus mass is rough and can be detected by the use of an explorer or a probe. Now, the outer layer of subgingival calculus is partially calcified. On the surface, it's thick, mat-like, soft layer of dental biofilm. So remember, biofilm is always on the surface of dental calculus. The outer surface of biofilm on subgingival calculus is in contact with the disease pocket, epithelium lining, where it can't be removed with daily self-care. And there are different types of calculus deposits. You've got crusty, spiny, nodular deposits, ledges or rings, thin, smooth veneers, finger or fern-like formations, individual calculus islands or spots, as well as supragingival upon subgingival deposits, where it just literally grows from underneath and starts collecting on top of the gum line area. But formation time means the average number of days required for the primary soft deposit to change to mature into the mineralized stage. And the average time is about 12 days, with a range from 10 days for rapid calculus formation or formers to 20 days for the slower calculus formers. Mineralization can begin as early as 24 to 48 hours when the patient's personal daily oral hygiene is neglected. 24 to 48 hours. So can you imagine you've just spent 3 hours trying to clean a patient's teeth, and they come back from Monday, they come back on a Wednesday, and you're hoping to complete them, and those mandibular anterior root surfaces are covered with calculus yet again. We've seen it happen. The good news is it's very easy to remove because it's not embedded into the cementum, but it does happen that fast with some patients. The formation time depends on the individual's tendency, but is really strongly influenced by the roughness of the tooth surface, as well as the tearing characteristic of the personal biofilm control measures. So estimation of the approximate formation time for an individual can really be helpful when planning instruction and counseling, as well as treatment planning for professional care and the frequency of maintenance appointments. A low calculus former might not need to come in as frequently or have as meticulous oral hygiene as a fast calculus former. Now, calculus attaches in different ways, and the ease or difficulty of calculus removal can really be related to the manner of the attachment of the calculus to the tooth surface. And several modes of attachment have been observed by conventional histological techniques as well as electron microscopy. And any one tooth in any one area or more can have more than one type of calculus attachment. But when studying the attachment types, the character of the hard, smooth enamel surface and that of the rough, porous, cemental surface can be compared. And you've got three general modes of attachment that include attachment by means of acquired pellicle. And the pellicle, as you know, is that thin, acellular, homogeneous layer positioned between the calculus and the tooth surface. And calculus attachment is superficial because there's no interlocking or penetration that occurs, and the calculus can easily be removed. Pellicle attachment occurs most frequently on enamel as well as newly scaled and planed root surfaces. Then there's also attachment to minute irregularities to the tooth surface by mechanical locking into undercuts. Dentin irregularities include cracks, lamina, and carious defects. You've got cemental irregularities that include tiny spaces left at the previous locations of the Sharpie's fibers, the resorption lacunae, root gouging from improper scaling, and cemental tears. It's difficult to be certain that all calculus is removed when it's attached by this method, because the calculus becomes locked into those irregularities. And then you also have attachment by direct contact between calcified intercellular matrix and the tooth surface. An interlocking of inorganic apatite crystals of the enamel and cementum with the mineralizing dental biofilm or calculus. And research suggests that this mode of attachment results in a portion of the calculus that is prone to fracture being removed, and it may leave calculus crystals attached to the tooth surface. And the remaining calcium phosphate crystals may serve as a nidus for biofilm formation. There have been long-standing debates over whether subgingival calculus really has a role in periodontal disease, and despite the debate, the disease-producing bacteria held in the rough surface of the calculus really perpetuate the inflamed state of supragingivally for gingivitis and subgingivally close to the pocket lining the epithelium to promote periodontitis. So the cornerstone of non-surgical periodontal therapy is to control biofilm deposits by the patient on a daily basis, supplemented by definitive professional calculus removal to reduce or eliminate gingival inflammation and bleeding on probing. Subgingival biofilm development as a result of the downgrowth of supragingival biofilm is known. So subgingival biofilm contains pathogenic bacteria that causes the inflammation as well as destruction of the soft tissue and can lead to a loss of attachment. So we need to be able to concentrate our efforts with our patient on biofilm control. Subgingival calculus is always covered by masses of live biofilm bacteria. With its rough surface, permeable structure, and porosity, calculus acts as a reservoir for endotoxins and tissue breakdown products. And the bacterial mass is in contact with the diseased pocket epithelium and promotes gingivitis and periodontitis. Irritation of the pocket lining stimulates greater flow of that gingival crevicular fluid, which contains minerals for more subgingival calculus formation. So calculus is a predisposing factor in pocket development in that it provides a haven for the collection of bacterial masses on that rough surface. But it's the biofilm that is the primary etiological factor. For clinical characteristics, identification of calculus prior to removal of the deposit are based on your knowledge of appearance, the consistency, as well as distribution. So appointment planning, the selection of instruments, and the techniques really depend on your understanding of the texture, the morphology, and the mode of attachment of the calculus. And Table 21.1 lists a summary of the clinical characteristics. But for supragingival examination, you've got your direct examination, you're using the compressed air and light. For subgingival, you're using visual examination. A dark edge of calculus might be seen just below the gingival margin. You're using gentle air to try and deflect the tissue, so you can use direct observation. You're using transillumination on the anterior area. It will show up as shadows without calculus, stain, or thick deposits. The enamel is really translucent. You're looking for gingival tissue color change. Dark calculus may actually reflect through the thin margin and let you know that there's subgingival calculus there. Sometimes it looks like a little piece of pepper is stuck underneath the gum tissue, and that's just old calculus. Tactile examination, you're probing first, and you're getting a sense of calculus there. Then you're exploring to get a better sense. And each subgingival area really needs to be examined carefully to the bottom of the pocket around each tooth. You're using radiographic examination. It's really not that useful for calculus detection except for the proximal surfaces. And you know that if you can see calculus on the radiograph, there is a lot of calculus present because it doesn't show all the calculus. The bone loss, you can check radiographically as well. And there's also something called dental endoscopy, where an endoscope is used in the deep pockets where you can actually use a device, a microscope, and go down and take a look at what that root surface looks like. So this is supragingival calculus. It's something that you're going to see on most of your patients. We just can't wait to get our scalers in there and get this off. Mandibular anterior, very common site for it. Again, think about where the Stenson's duct and Wharton's duct is. Now this is somebody who also has more calculus deposits. You can see the crowding on the mandibular anterior teeth, and the calculus goes over the to the incisal edges. You can see calculus going up to the occlusal surfaces on the patient's left side, so they're probably not chewing. They might not have maxillary dentition there, but this is heavy calculus. Radiographic calculus, again, you can bet that it's going to be showing up with your Explorer more than what you can see on the radiographs. So, how do you prevent calculus? Well, you have to be able to reach the biofilm in order to prevent it. Risk factors related to calculus formation are really those similar to dental biofilm formation. Patients at risk for calculus formation really need personalized counseling, and there are several methods for managing and minimizing calculus formation, including effective daily biofilm removal, professional non-surgical therapy, chemotherapeutic agents like pyrophosphates in the toothpaste, those anti-tartar, or triclosan in the Colgate Total, which is an antimicrobial. But the main thing is personal dental biofilm control, and that's removal of the dental biofilm by approximating selected brushing, interdental care, supplementary methods. So you are customizing things for the patient. The patient needs to understand the necessity for individualized daily biofilm removal. One power brush might be better for one person than the other. One size of a toothbrush might be better for one person or another, and one brushing technique might be better for one person over another. So you really want to individualize the care as much as you can. Patient education includes identification as well as hands-on demonstration of the oral hygiene aids that you're using. It's never just show, it's show, tell, do. You're showing them, you're informing them, you're demonstrating them, and then you're having the patient do it themselves. But there's also follow-up over continuing appointments to continue to motivate and refine techniques for the patient. So you're not just doing one plaque index, for example, on that patient. When you have that patient coming in and you're at that point of the process of care, each subsequent appointment, unless it's from a morning to an afternoon, that's the next day, you are re-disclosing that patient and getting a new plaque index, and you are refining your oral health education for that patient. So we're doing plaque indexes, we're getting the patient incorporated into what the numbers mean, we're refining techniques, we're identifying dietary behaviors that may be enhancing biofilm growth, such as sugar-sweetened beverages, a high-rice diet. They need to know that regular professional supervision is important, as well as keeping their maintenance appointments. We need professional removal of calculus. That's where we come in. You don't want patients going to Brookstone or Amazon and buying their own dental instruments thinking that they're going to be able to do this on their own. So we need to emphasize good oral hygiene and routine professional removal. Low levels of supragingival and subgingival calculus can really be demonstrated on a long-term basis. So one person might need to be coming in every 2 months to keep up with their calculus formation, versus somebody else might be great at 8 months. So we're also individualizing the frequency that they need to come in. Now there's also anti-calculus or tartar-controlled dentifrice or toothpaste and mouth rinses. And calculus-controlled dentifrices currently available aim to inhibit the calculus crystal growth, which in turn will lessen the amount of calculus deposits on the teeth. And the toothpaste that do not have an effect on existing calculus deposits. So they can't have a mouthful of calculus, start using tartar-controlled toothpaste thinking that it's going to work. A patient who can't control supragingival calculus and then can't achieve optimum gingival health, an anti-calculus dentifrice may provide some motivation as well as a supplement to the mechanical biofilm removal. And there's also other chemotherapeutic anti-calculus agents. There's tartar-controlled mouth rinses that contain pyrophosphates, zinc citrate, or zinc chloride, or triclosan. So know what those chemicals are just by name: pyrophosphate, zinc citrate, zinc chloride, or triclosan. Soft tissue irritation or dental hypersensitivity may also be a side effect of those anti-calculus. So it's important, again, that we always finish with documentation, and a permanent record of the patients that are subject to the formation of calculus needs to include the calculus deposits as described on the initial exam and charted to show the location, extent, and distribution, as well as the extent of super and subgingival calculus. Is it slight, moderate, heavy? The location of it, the tenacity of it also is something that we include. Some calculus is easy to remove and others isn't. So we want, ideally, good oral hygiene and frequent professional care for the complete scaling that is really keeping the patient at low levels of supragingival and subgingival calculus. We need to keep things manageable for our patients, so we need to bring them in frequently enough to make our appointments manageable for them. They need to know what calculus is and how it forms and what dental biofilm is and how they can control things themselves. They need to know the reasons for producing as calculus-free environment as possible by biofilm control measures, and what you expect from the use of an anti-calculus dentifrice. It does not solve all the problems. Anti-calculus toothpaste really only work above the gum line area on enamel. They don't do a good job of inhibiting calculus formation on root surfaces as well. And if calculus is already there, it's not going to do anything for that. So that's the end of Chapter 21, Untitled Calculus.